So this takes us to another common question that was in the Q&As that you'll see in the handouts. Folks were asking what happens when a family physician has moved away or stopped practicing. And one of the places where we looked for some of the immediate answers is using the dispensing authority or dispensing scope of practice as opposed to the prescribing authority. So we know that a prescription is valid for 1 year, and therefore the dispensing options may still be available before using the prescribing authority to address the situation. Again, professional judgment is needed when serving patients with no primary care practitioner, and you'll find guidance in the general provisions document as well as the other reference documents pertaining to each prescribing activity. And just as a reminder on the slide, the relationship, another kind of mindset that we thought where people were kind of getting stuck was just what does it mean to have an active patient-practitioner relationship? So as someone had noted in the inquiries, is that relationship is defined quite broadly. So it's a relationship between a patient and a licensed pharmacist or a practitioner in which a professional service is provided for the purposes of optimizing the patient's health or drug therapy. And just a reminder as well, in the Prescription Drug Act, a prescription is an authorization given by a practitioner directing that a stated amount of any drug or mixture of drugs specified in it be dispensed for the person named in the authorization. So when you have a prescription, that is actually the result of an active patient-practitioner relationship. And that doesn't have to be a family physician or a primary care provider. It may be the patient's primary care provider, it may be family physicians, nurse practitioners, but it also may be practitioners working in emergency rooms, walk-in clinics, or other practice settings. So again, just a reminder that there's still the dispensing scope of practice available in those scenarios. Next slide, please. And although we know that the pharmacists are dedicated to serving patients, and we could see that in some of the questions coming through, we just need to remember that pharmacists are not trained to be the most responsible health provider, nor do they have access to the health system privileges that are required to be the most responsible provider. So these provisions are just as much to protect the pharmacist as it is to protect the patient. Next slide, please. Another theme that came up a few times, and we've heard this in the past as well, is about professional judgment. And actually the bylaws contain a clause on professional judgment, just that the pharmacist must have reasonably satisfied themselves that the prescribing decision is appropriate in the circumstances based on their assessment of the patient, and that prescribing decision is proper in the judgment of the pharmacist. Now, previously, the way the bylaws were, there were more limited opportunities for the pharmacist to apply their professional judgment. However, with the expanded authority, pharmacists will be facing more situations where they'll need to use professional judgment to determine which prescribing authority they can use in that situation. On the right-hand side are just some common examples that you will see in the slides, and examples of where, again, professional judgment is needed. So, for example, in in-term supply, what is the quantity sufficient for the patient until the date of their next practitioner appointment? So the pharmacist will be thinking of many different factors. Emergency supply, what's the quantity of drugs sufficient to meet the reasonable needs of the patient where an interruption in therapy would result in imminent harm? Another question we get is the patient is chronic and stabilized on a drug. I know previously it was typically there was a period of time specified, and we're moving away from that with the hopes that, again, this can be used for the good of patient care, and that this judgment will be used prudently. We've also got reasonable attempts to contact the prescriber before altering or continuing prescriptions issued by a practitioner. So when you read these, the general provisions and the other documents, you'll see mentioned throughout that pharmacists are to use their dispensing scope of practice first before prescribing, simply because when you receive a prescription, that is an authorization given by another practitioner. That is not the practitioner authorizing the pharmacist to alter or continue the prescription. So we are really reinforcing the dispensing scope of practice as well as a strong foundation for the prescribing. Again, we mentioned patients with no primary practitioners, so knowing where to refer them. And also we often get questions around emergency situations when someone is having an obvious asthma attack or a diabetic and another health professional is not readily available. Again, what is needed in the time is professional judgment. Again, there are further examples of these themes in the handouts provided. Next slide, please.
So we've seen lots of examples earlier where illustrated that prescribing does not equal dispensing. So thinking of them as very discrete practices. And then we've also received some questions that confuse prescribing drugs, which is under Part K, with administering drugs by injection, and that authority is under Part L of the bylaws. And so, for example, one question asked, is giving flu and COVID vaccines considered to be administrative prescribed? No, administering publicly funded vaccines are under the authority of Part L bylaws, and that is the administration of drugs by injection and other routes. And then the second question that you see here on this slide is an illustration of a question that touches on 3 discrete scopes of practice. Part K, prescribing drugs, Part L, administering drugs, and Part M, laboratory tests. And so we're hoping that by this you kind of take away some helpful ways to navigate the legal requirements of each of these discrete scopes of practice. So instead of using words like give or provide, it will be helpful for you to speak about the distinct scopes of practice by using the verb associated with them. So for example, are you dispensing or are you prescribing? If you're prescribing, you will look to Part K of the bylaws. If you're administering, you'll look to Part L of the bylaws. And so then again, just kind of having that takeaway of knowing where to look for the distinct scopes of practice and to use whether you're prescribing separately from whether you are dispensing.